It doesn't? Yeah, it doesn't sound like it is from up here. So I'm Leslie Morrison, and I'm a pediatric neurologist at the University of New Mexico. About a year and a half ago, I was brought into this transverse myelitis situation by Cody Unser, who hopefully most of you will meet. And about a year ago, as many of you know, some of you were there, we met in Baltimore, and we had a fairly large meeting there. And then more recently, we had a small meeting in California, and I think there are 3 families here from that meeting. This is the same talk that I gave there, so you're dismissed if you don't want to hear it again. But I started out my career as a physical therapist in pediatrics, and so although I'm much more of a diagnostician at this point, the treatments that I learned about as a physical therapist have become very important to me, particularly in chronic motor disabilities. So I was happy that others chose the sensory arena, where I'm going to focus much more on the motor problems that occur in transverse myelitis. I'd also like to thank Sandy for the extensive work that he and others of the TMA have done to put this meeting on, and I think it's got a lot of noise. Very exciting to see this many people, this many children with transverse myelitis in one place. So I wish it could have been even larger, but this is extremely exciting. So thanks everybody for coming. So motor problems in transverse myelitis. The first big problem is weakness of the muscles. We see a lot of spasticity, but combined with that are the things that children cannot do because they don't have the power in their muscles to do them anymore. And as most of us focus on gait, ambulation, walking, but there are many other things that you can't do, such as transfers, just standing up and being the same height as the rest of your peers. So that's a real big thing for children, is the weakness. Next is the spasticity. And that is the increase in muscle tone that we see, the stiffness that also can prevent children from doing things that they want to do. And we're going to talk a lot more about that. Spasms. How many of your kids have spasms? So maybe about 25 to 30%. And those spasms, I think, can be very embarrassing for children, and they can also be painful. So if you could prevent the spasm, maybe some of the pain that comes because of the muscle spasm could be prevented. Next is lack of dexterity. So even if a child has the strength to stand up, they lack that mobility and the coordination that it takes to look good. And as you all know, with your children, especially after they get past about 5 or 6, looking good is probably one of the most important things to them. And then fatigability. The muscles are working much harder. They're working hard to relax, and they're working hard to power the child. And so they really do experience quite a lot of fatigability. And I think as parents, you might notice that that's irritability. Your child gets a lot more moody when they have been trying all day to do things, and then they can't do them after a certain point in the day. It's not the same as myasthenia gravis, where the muscles just get weaker and weaker. It's more of a tiredness of having to work so hard. So we'll do a little bit more anatomic review here. Dr. Kerr did this verbally and with a little bit of a diagram. So let me just show you what the main tracts are here. We talk about the upper motor neuron and the lower motor neurons. So what I'm showing you here are upper motor neurons, neurons that come from the top of the brain and then go down to take your idea that you want to move all the way down to where it can connect with the one that's going to move the muscle. So these tracts, the most important one we think of is called the corticospinal tract. And what you might notice doctors doing is using this term quite a bit. We're saying the corticospinal tract dysfunction. They have a pattern of movement suggestive of corticospinal tract dysfunction. And it doesn't matter where along that axon or that wire the injury is, it sort of manifests the same. So it could be coming from the top here as if you'd had a stroke, Could be something in even the brain stem here, or it could even be down here in the spinal cord, which is where we're concerned about today. There are other motor neurons that have influence there as well. So those are the tectospinal tract, reticulospinal tract, vestibulospinal tract, and those are mostly coming from the brain stem down into the spinal cord. So let's begin talking about this with spasticity. What is spasticity? By definition, it's a heightened response to stretch that is velocity dependent. So that means that at slow speeds, you might not elicit spasticity. You might not get that kind of tightness that occurs. It might take just a certain velocity for that to occur of stretch. And everybody is different. Some kids, it doesn't take very much. It also is very dependent on their emotional state. So if a kid is very excited, then it doesn't take as much to set that off. It could be a noise, it could be stretch, it could be a lot of different things that can kind of increase your chance of having spasticity. It comes from the Greek word spastikos, which means to draw in. I find that to be a very interesting term because of the emotional connotations of it. I think children with spasticity draw in emotionally because they know they look different and they move differently than other children. So it has both the physical and the emotional manifestations. And then other components of upper motor neuron, corticospinal tract dysfunction. Those include something called clonus, and I'm sure most of you have seen that in your children. When the neurologist comes to examine your child and they stretch their toes up quickly, that elicits this reverberating circuit back and forth where you're stretching alternately one muscle group, then that in turn reacts and stretches the opposite muscle group. And so I've actually had clonus when I'm very, very tired. So if you're sitting in a certain position, you've been skiing all day, something like that, you might experience a little bit of clonus yourself. But most of the time it's an abnormal sign of upper motor neuron injury. Then again, we talked about the velocity, how quickly it takes that stretch. So if you move very slowly, you may not set it off, and that's part of the value of all the stretching routine that we're talking about. If you move suddenly, you're likely to get a spastic reaction, but if you stretch, lengthen things a little bit first, and then move slowly into positions, you're much less likely to set off that spasticity. Another sign is the one that most kids hate. It's when the neurologist brings out the key, and that's called the Babinski sign. They might be interested in the kind of key that the doctor is using, whether it's a BMW key or a Saab key, but they don't like the feeling of having their toe scratched most of the time. So that just goes along with the upper motor neuron signs. It actually can even be spontaneous. I see a number of children with spasticity whose toes go up all the time. So when you scratch the bottom of the foot, the big toe goes up, the toes flare out. So it's a very characteristic reaction. You probably all know what that is. And then, so we've talked a little bit about the upper motor neuron. Now, where is it connecting? It's connecting down in the spinal cord here with a pool of motor neurons. So the descending influence here can set up both excitatory and inhibitory input and kind of set that motor pool so that it might behave normally, it might take the cues normally, or it might behave abnormally if you don't have if you don't have inhibition from above. So one of the big functions of the upper motor neuron is to inhibit or relax this motor pool. So when you take that away from above, your muscles become overly excitable. And that has to do with information that they're receiving from the muscle itself, called the muscle spindle, the alpha motor neurons, the gamma. So it's a very complex system which I don't even understand, and I've tried to learn it many, many times. But it helps us a little bit in determining what medications might be valuable here. And then how do we look at this function? How do we grade spasticity? I've given you the criteria for the original Ashworth scale. I don't know if you've all heard of the Ashworth scale. It's been modified since then, but just to give you an idea of really how we're looking at it. 0 is normal. There's no increase in muscle tone. That's what our goal is. We're striving for that. 1 is a slight increase in tone, giving a catch when the limb is moved in flexion or extension. So that's the classic clasp knife problem, when you're stretching and stretching and then suddenly the muscle gives way. And when you do stretching in your own child, I'm sure you've been aware of exactly what that feels like. Number 2, more marked increase in tone, but you can still flex and extend the limb. 3, considerable increase in tone with passive movement difficulty. And you can see why they've modified this, because it's a very qualitative assessment. It's really your descriptions. But 4 is limb rigid in flexion or extension. And some children do have so much spasticity that they are rigid. That means that they're not going to be able to relax enough to do things that they want to do. Now, so what? So you have a little spasticity, maybe that's actually a good thing. Many children, adults, will actually stand on their spasticity. So if you have weakness, you maybe want a little spasticity because that will give you a little bit of power there. You can rely on that a little bit for transverse as well as sometimes for walking. But if you over-treat spasticity just because it's there, you may wind up with a decrease in overall function. So you have to really balance what the child needs, exactly what's the functional measure that you're after, not just is it there, treat it. So why do we treat spasticity? Well, first and foremost, we want to make the child more comfortable, but we also want to make sure that they don't get fixed deformities. So if that's possible, you want to decrease the spasticity enough that you can get full range of motion, and that means the extent of the joint, moving all the way into extension and all the way into flexion so that that joint experiences what it's supposed to experience. We also might want to treat spasticity because the spasticity might be so severe that you can't move one leg at a time and you need a reciprocal pattern of gait in order to ambulate or to walk. With these patterns that we see with spasticity, you have an increase in walking up on the toe, or what's called plantar flexion. And you want to combine that with devices that help hold the joint in a certain position, and those are called orthotics. I'm sure all of you know what those are. It's orthotics here. Preserve independence in self-care. So what we want is for a child to be able to maybe stand up on their own enough to transfer from their wheelchair onto a toilet. We might want to decrease their spasticity enough that they're able to do that, but not too much so that they're not able to do it. So, and then the other thing is because the legs tend to come together at the knee, it can make it much harder to do personal hygiene. So kids want to be able to take care of their own personal hygiene, cap themselves. We might need to decrease the spasticity enough that they can do that. I mentioned transfers already. One big problem is if you're standing up on a pivoted toe, you really don't have much of a base of support. If you can bring that heel down, that gives you a much broader base of support. And so that's a reason why you would want to treat spasticity. And again, moving around in bed. Just turning over at night. You may be inhibited from turning over at night because your legs are too stiff. So what are some simple measures that can be done to avoid setting off spasticity? You can always be on the lookout for things if there's a change. So if a child suddenly becomes more spastic, there could be something very treatable, very important to treat that's causing it. One important thing is bladder infection. Even a distended bladder can set off spasms or increase spasticity. So you might see a child sitting there with clonus where they don't normally have that reverberating circuit. Bowel distension, severe constipation, which children may not tell you about, might be the cause of them having an increase in their muscle tone. Even other little things like an ingrown toenail or just pain, a thorn or something that they can't really tell you about, they can't feel, might be causing the spasticity to worsen. And then a really important thing, which is blood clots in the veins that drain the legs, because our children don't move normally. They may be sitting, especially in teen years, for hours and hours at a time. So really think about that as a possibility. So how do we treat this? So we've defined it, we've described it with the Ashworth scale, we've talked about some simple measures that might be causing worsened spasticity. But what else can you do? So here's the stretching issue. You have to stay flexible. You have to maintain that range of motion. Now, we don't really know exactly how many hours a day you need to spend, or minutes a day you need to spend stretching. But we do know some things about stretching. One is that it needs to be done very slowly. And you need to maintain a stretch position for hopefully about 60 seconds if you can. So when you go through your stretching routine, it needs to be at a time when you're going to have time to actually do adequate stretching. And it probably should be more than once a day. And I know once a day is a tremendous amount of time for every child, but it probably should be done in specific time. So you know they're getting it in therapy, but probably before you get them going in the morning if they're very spastic, and even before bed at night. It might help them sleep a little better. You also need to stay strong, so you need to do a strengthening regimen as well. You need to do some exercises that increase power. They don't have to be all boring. I agree. These can be done over a big round ball, and the therapist can help you with that. They can be fun while they're watching TV or while they're interacting with a child, another child, or a toy. So all these things can be done as fun as possible. Use orthotics during the day to help maintain the stretch. So you want to make sure that you don't stretch and then send them out running away on their toes. You want to make sure that their heels are 90 degrees if you can throughout the day. Stay mobile. You want to stay mobile because you need to do wheelchair positioning, you need to have turning over at night, and you need transverse and ambulation. So you guys know this. Who are your most important people here? Your PT is probably the most important one. But the orthotist is also important, the person who makes your kids braces, because there are lots of different ways to make braces, and you need to have a good relationship with them. You need to be able to take the orthotics and get them modified if your child is having skin breakdown, because that skin breakdown might be increasing the spasticity. Also, you need your orthopedist, because some of these children will need some orthopedic surgeries. So you need to have a good relationship with them as well. You need your neurologist and or your physiatrist. So rehab doctors and neuro rehab doctors are both trained to deal with these kinds of issues. And then your wheelchair vendor, also very important, because the place where your kid is most of the day is in the wheelchair. Hopefully in and out of the wheelchair, but a lot of time spent in their wheelchair. So that wheelchair has to fit basically like a glove. It has to be perfectly set up for their own dimensions. So medications. How many of your kids are on medicines for spasticity? Yeah. I think that in the adult population there are actually more people on medicines. I think as a parent myself, I hate giving my kid medicines. I will avoid it at any cost. So I really understand how hard it is to make a decision to use medications in your child. However, some kids really do need them and really do benefit from them. So the big one is baclofen. It's a GABA analog. In other words, it looks like an inhibitory neurotransmitter called GABA. It's thought to inhibit the release of the excitatory neurotransmitter. So in a way, it functions like that upper motor neuron is supposed to by inhibiting what's going on down below. It's available as a tablet, as you know. It can also be made in a liquid preparation if you need to. In adults, you can go up to 80 milligrams per day. I've heard of many adults on much more than that. But it causes problems with central nervous system function. It can cause lethargy, which means just sort of fatigue and inability to kind of initiate things, weakness, nausea, paresthesias. Even in itself, it can cause some sensory changes. It can cause seizures. if suddenly withdrawn. So what you don't want to do is get on a plane to fly to Columbus, Ohio and forget your baclofen because they really do need to be weaned off of it if they're going to go down. Valium, diazepam, also thought to be an agonist of GABA, that inhibitory neurotransmitter at the spinal cord. Comes as liquid tablet and even rectal forms. Now the rectal form is used mostly in epilepsy to stop a seizure suddenly, but it actually could be very valuable if you have a child who goes into a sudden spasm. You may be able to get this rectal gel inserted and relax their muscle tone before they get really severe pain. Sedation is the biggest problem with it. It affects the brain. Dependence, some people describe that they have to keep going up more and more on their Valium. And then it can cause cognitive impairment, which is not thought to be permanent. But we really don't know exactly how these affect the developing nervous system. So there's research to be done in that area. Dantrolene. So dantrolene is a pretty commonly used medicine, but it's different. It works on the muscle itself. It prevents calcium ion release, and it reduces muscle contraction, again, right at the muscle itself. It comes as a tablet or a powder that you can make into solution, and you can, in adults, can give up to 400 milligrams 4 times per day, which is an astronomical dose, but that's been described. The big problem is reports of fulminant, meaning very severe and acute liver dysfunction. So your kids on Dantrium and actually probably baclofen and maybe some of the other medicines too need to have periodic checks of their liver function to make sure we're not sort of slowly causing problems with liver. A newer medication is called Tizanidine, and that's it's very similar to the blood pressure medicine that Dr. Barnes talked about, which is clonidine. It's very similar. It's called an alpha agonist. And what it does is it probably inhibits, again, from above, so it's a central nervous system. But because it's like a blood pressure medicine, it actually is a blood pressure medicine, and it can lower the blood pressure. So you have to be a little careful about that one as well. It can cause a dry mouth. It can cause sleepiness. It can cause asthenia, so just kind of lack of energy, and increased spasms or muscle tone. So each child has to be assessed on each medication individually, hopefully one at a time if you can. And only change one thing at a time in all of these medications. Comes as a tablet. You have to crush it for little kids. 4 to 12 milligrams every 6 to 8 hours as a final sort of adult dose. Alternatively, people have looked at some of the anti-epilepsy medicines for spasticity. One of them is gabapentin. And gabapentin, although designed as a GABA drug, really is not, probably has a different mechanism of action, but does seem to, it's very useful in some patients with neuropathic pain, and as a side benefit, you might notice a decrease in spasticity as well. Another one is an antiviral medicine called amantadine, and some people have reported decreased muscle tone with that, but I'm presenting these as really not substantiated well in the literature. And then 4-AP, how many of your kids are on 4-AP? Anybody? 4-AP is very difficult to get. Dr. Kerr does recommend it in some of your children, or might have recommended it in some of your children. And I'm not going to talk more about that, except that it works by a different mechanism than all the others that we've talked about as a potassium channel blocker. Oops. Botox. Anybody have Botox injections for their kid? Yeah. So Botox is very popular now for Botox parties. You can go, have some wine and have some Botox injections with your girlfriends. But for our kids, it's a very serious treatment. What we want to do is we want to decrease their spasticity by using this treatment. But it requires an injection. Kids don't like shots. So you can do things to decrease the sensitivity of the skin when they get the injection. And you can also give some sedation along with it. And I think most children will tolerate having a shot if they are also, a little more comfortable. There's a lot of rules and regulations about how to use sedative medicines for procedures like this in hospitals. And so we have to be very careful. We have to monitor their blood pressure. We have to monitor, make sure they wake up fine. So there's a lot to it, and it can make it very expensive, and it can make it a lot more of your time and your child's time. We also like it to be done with EMG guidance. And what that means is that there's a little machine, it's called an electromyograph, that you can use to make sure you're in the muscle. You want to make sure that you apply this Botox directly to the muscle if you can, even though if you get it pretty near, it probably will work. But we'd kind of like to know specifically what muscle we're in. It may take a few days before it becomes fully effective, and it may last for several months. There are kids that might need Botox injections once a year. Others, it's gone within even 2 months. So everyone has kind of an individual duration. And you cannot do Botox injections alone. You have to do these with your therapist. They still have to wear orthotics. You might consider using serial casting along with the Botox injections, which means that you're going to gradually be stretching the muscle. And then tomorrow I'm going to talk a lot more about electrical stimulation, somewhat of still a mystery to us how to use it, but I'm going to skip this. And then other treatment modalities. What else can you do? So say you don't want to give your kid medicines, or your child has tried medicines and they don't work, or they have side effects to the medicines. Maybe you could do some other things. And so there's a lot of techniques that can be used by the therapist and taught to you for a home program. Those include vibration. Little vibrators can make a tremendous difference in muscle tone, especially if kids go into spasm. Sometimes you can actually interrupt a spasm by just applying the vibrator. Cold applications can be really valuable. Topical anesthetics, a technique called spray and stretch, where you spray it and then you do a slow stretch to the muscle. And then acupuncture, which unfortunately has also not been well established as a treatment and not well substantiated as a treatment either. Orthotics, it's very important that you position the joint. Some people need to do this at night as well as during the day. So you have to get something that works pretty well, is pretty comfortable for your kid and doesn't cause skin breakdown. They may need lots of padding with it. But one of the thoughts is that this actually inhibits those stretch reflexes too. So when we set off the spasticity with the stretch reflex, if you can use a brace or an orthotic, you may be able to decrease that sensitivity. And I mentioned serial casting along with Botox. It can be used without Botox as well. And what our idea is here is that if you put the muscle at a stretch, after 7 to 10 days in that position, you can get just a little bit more range of motion, and then just a little bit more. So there are some proponents of repeating this 4 to 5 times. It also depends on how your child responds to it. If you take the cast off and they go into a spasm worse than ever, then maybe that technique is not working for them. But most kids, actually, you can gradually get more and more range of motion. You can do therapy along with it. You could do some weight bearing in the cast, but the idea is that once you do this process, overall you're ahead of the game, not where you started. So now, what can you do that is more invasive, but perhaps more effective? So intrathecal baclofen has been around for some time now. It's used in reduction of spasticity. It's been used mostly in cerebral palsy. And the most effective use of it has been in children who have more spasticity in their legs than they have in their arms. And that describes the majority of kids with TM. They have mostly problems in their legs, less dysfunction in their upper extremities. But all it does is decrease spasticity. Now, if you decrease spasticity in the legs, sometimes you get a side benefit of having a little bit more functional use of the arms as well. So some kids with higher level in TM might actually benefit from this. It requires a test dose. And so what you do is insert the catheter, like a lumbar puncture, like a spinal tap, insert the baclofen there, and observe to see what effect that has on your child. There's a specific dose that you try, and then a specific protocol for observation of that. But if your child has a great reduction in their muscle tone with this, and they can be more functional with the reduction of their muscle tone, it may be something to consider. It's thought to be a permanent procedure, although ultimately the device will need to be replaced because of the batteries. They've been working on smaller devices because the size of the device, which is about the size of a tuna can, is a problem in young children. They just aren't big enough to handle the device. It's usually placed here in the abdominal region, and most of the time it's very well tolerated, but it has to be refilled periodically. It depends on the rate that you're giving the baclofen into the space around the spinal cord. If you use a lot, we have kids on 500 micrograms per day. There are people on 1,000 micrograms per day. If they use 1,000 micrograms per day, then they're going to run out when that's gone. And it can be, like I said, as short as weeks apart where they need these refills. Rarely does it cause kids to be too sedated because it's only bathing the spinal cord. It's not going up around the brain. There are rare reports of something called gliosis or scarring, some of what Dr. Kerr showed a little bit with the pathology slides. And we don't really know a lot about that. It's kind of newly reported, but it's something that if your child suddenly has worsening of their bladder function or worsening of their spasticity, you need to make sure that that isn't the cause. But it's very rare. It's very expensive. So anatomically, this is a section of a spinal cord, but it includes both the part that goes out to the muscle, the ventral horn, and also this incoming stimulus from the muscle and from the skin called the dorsal root. So all the sensory function here can sometimes be interrupted to cause decreased spasticity going out. This procedure is called a rhizotomy. Selective posterior rhizotomy, where certain of the rootlets are cut permanently to disrupt spasticity. It's used in kids with spasticity, legs worse than arms. But the problem with this is, should there be actual treatments for regeneration, then you're dealing with a system that's been altered. So it may be something that you would really only want to consider if your child really has significant spasticity that you want to deal with permanently. It's not reversible. And then I guess talking a little bit about, I think, what Dr. Pidcock is going to address tomorrow, which is weight bearing. Now, weight bearing, we think, is important to help decrease spasticity and help give better input to motor function. So I'm only going to talk about it in terms of its use to help decrease spasticity and improve motor function. So if you can have your child stand every day, what's important about it is that they stand in a very well-aligned position. You don't want your child standing like this. If they're bent over, then they're not getting the input to their joints, and the stress lines on their bones is not going to be proper. The goal is to also increase their mineralization so that they're at less risk for fractures. And all of our children have a higher risk of fractures than children who don't have paralysis. You definitely want to make sure they get adequate calcium supplementation, that they have vitamin D, especially if you live in a cloudy environment. And also we're looking at Fosamax, which is a treatment to help preserve bone mineralization in children. We're starting to use it a little bit in disorders where we know that there's bone demineralization. So I think that's going to be a good treatment. And then I'm going to leave to Dr. Pidcock more discussion about walking. But I just want to put in 2 cents worth. Not everybody needs to walk. It's okay if you can get around, you have wheels, you have mobility, if you can do the things that you want to do. So you shouldn't not give your child a wheelchair if they want to go to the mall. if they go to an airport. I mean, there are definitely situations where even though your child may be walking most of the time, you want to relieve the stress of having to do that. I think the Osgood Schlotter's question was a very good one, because we may be overstressing his joints in order to keep him upright and walking. So it's a real catch-22. But I think that many people are very happy with wheelchair mobility. And it's something that is an emotional decision. Your child needs to be involved in it, but it's not the end of the world if they're not walking. And I guess ending with question of bionics, which will lead to my talk tomorrow about electrical stimulation and what we can do with that, or what we know about that at this point. So I'd be happy to address any questions. Yes?
Spend much time talking about surgical approaches to severe spasticity and contractures. Does that mean that almost always some combination of therapy that will relieve severe contractures without surgery, or is it just an area you kind of talk about later?
No, I'm not going to talk about it later. I think that my viewpoint is to try to do as much as you can non-surgically before you get to the point where you change things permanently. And part of that is that I have a fair amount of experience seeing surgical outcome, and I think that it's very surgeon dependent, and that it needs to be done in combination with all the other things as well. Because if you just rely on surgery to fix the problem, many of the contractures recur, or you go the opposite direction. So you have a new deformity opposite of the one that you were trying to correct. So I just think that it has to be done very carefully, and I do rely heavily on our orthopedic surgeons to do as conservative an operation as they can, to leave things as intact as they possibly can. Was there a specific question behind that? I'd be happy to talk to you later about it. Yes? So let's have a show of hands of parents whose children have had tendon transfers. Not very many. Muscle or tendon transfers.
Tendon release.
Oh, tendon release. So that's a different question. How many kids have had, how many of your children have had surgical procedures?
Actually, we're scheduled for one next week, so
2.5, almost 3. So a minority, really. There were a couple more questions. Yes, in the back?
How often would you check for liver function?
That's a good question. When we check for liver functions, we're hoping that we can catch something before it gets out of hand. So what I typically advise is every 3 to 6 months. Once a child has been on a stable dose, it could maybe be stretched out a little bit. And there's no guarantee that we're actually going to detect it before it actually happens. Some of these things happen very, very quickly. But it's a measure to remind us, I guess, if nothing else, that we need to be aware of that as a potential side effect.
And what's the typical test? I'm sorry.
The typical
Test?
Oh, it's you can either pick one liver function. My favorite is SGOT, but you can also pick a panel of liver function tests. So those would typically be SGOT, SGPT, and they actually have new names, AST and ALT, bilirubins. So I think, you know, we're, like I said, it's really